Hi, everyone. Welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine with experts from around the country. Today, we're coming to you live from the 10th annual Arthrex Team Physician Controversies course in Naples, Florida. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan. Team Physician Controversies is a 2-day course where experts from around the world come in to discuss the world of collegiate and professional athletes. We're going to be talking about diagnosis, all the way to treatment strategies to return to play. And we're lucky to have some of these experts in the studio with us to talk about their insights into the latest and greatest techniques.
We're joined today by Dr. Spencer Stein, an orthopedic sports medicine surgeon at NYU who has successfully integrated orthobiologics seamlessly into his practice. Dr. Stein is an assistant professor of orthopedic surgery at NYU Grossman School of Medicine and specializes in arthroscopic surgery and joint preservation. Dr. Stein, welcome to the show.
So happy to be here. It's such an honor.
Thank you.
We're excited to have you. So on this episode, we're diving into a topic that comes up all the time for us as orthopedic surgeons. So orthobiologics. But we're not just talking about the science. We want to talk about real-world application and how we can implement this into our practice. And more importantly, when.
Exactly. Now, we've discussed orthobiologics a lot on our show, like Catherine alluded to, but predominantly we focus on platelet-rich plasma or PRP. Today, we're going to focus on bone marrow concentrate with a deep dive into the Angel bone marrow processing system and the Vortex needle. But before we get into the details, let's zoom out a little bit. So, Dr. Stein, when you think about orthobiologics as a whole, how do you frame them for yourself and for your patients philosophically?
Well, I think, like you said, zooming out, what we want to think about is we're not just carpenters anymore, we're gardeners, right? We want the biology, we want the support. So whatever we do carpentry-wise or whatever we do mechanically, we also want the biology or the biomechanics. So I think about it in a lot of patients. And so, but the way to really think about it is there's two spectrums. There's arthritis patients and how can we improve arthritis symptoms and push off potentially joint replacement. And then there's the joint preservation patients, like cartilage patients, and how do we support cartilage procedures? And that's kind of the two baskets that I think about with my orthobiologics and certainly the bone marrow concentrate or aspirate.
Yeah, those are important points. And, sometimes patients come in and they want just like miracle injection. And we're constantly trying to reset expectations and really where does this fall within our practice? So Spencer, do you utilize bone marrow concentrate into your practice and how?
Yeah, I do use bone marrow aspirate. So what is bone marrow aspirate? So it's taking basically that bone marrow and aspirating it or sucking it up right into our syringe and then potentially concentrating it, or there's ways that you don't even have to concentrate it now. It just comes up like in a concentrated form on its own. And using that, right, to support whatever you want to do. So now it is interesting you say patients come in, right? Patients are always coming in and they want like stem cells and all this. There's these commercials and all this like fancy stuff. And we do have to like temper that because like there's no magic bullet right now. Nothing can 100% restore cartilage. Certainly you're not going to see like what we say KL3 and 4, like advanced arthritis reverse its course and not become arthritis. But there is some evidence, and there was a recent 2025, I think it was AJSM, looking at bone marrow aspirate concentrate injections in KL3 and 4, and there was like 90% responders. Yeah. So that was pretty convincing for me, yeah.
So it sounds like you're talking about BMAC or bone marrow aspirate concentrate as a standalone injection, but it can also be used as an augmentation during surgery as well too. So what led you to choose bone marrow concentrate over other biologics, either as a standalone or at the time of surgery?
Yeah, right. You said PRP. So I used PRP for a while. And then I think just with like more training, I got used, especially in surgery, using the bone marrow aspirate needle. And it's quite simple. It's not like a very hard procedure. Like after learning curve is probably 1 maybe. And certainly you can try it in a lab before. And so it's not hard. So you can get it in surgery. The patient's already on an anesthesia. So they're really not feeling pain from it. And really I haven't had post-operative issues either with pain at that iliac crest site because I take it anteriorly. And then, so why is it better than PRP? Well, there are some things that are better, certainly. There's osteo and probably mesenchymal stem cells and osteoprogenitor cells in there. They're probably low, to be honest, but there's something, and it's higher than PRP. And then there's also differences in your inflammatory modulators. So BMAC or bone marrow aspirate has probably a better anti-inflammatory potential than PRP, even leukocyte-poor PRP, probably because there's a higher amount of IL-1RA. Right. So it's like a little bit biologic-y, but it's a receptor agonist that will block a pro-inflammatory cytokine or signaling molecule. So those are like amongst the reasons that I like bone marrow aspirate.
Yeah, and it seems
Yeah.
to tip the scales, and especially with these challenging patients where we're trying to really keep them out of more invasive surgeries, and when perhaps their own biology or without this intervention, it's not enough. So, Spencer, I want to talk a little bit about the equipment itself, the centrifuge, and why is the Arthrex Angel centrifuge system? How is that helpful to you? And tell us about how its ease of application is.
Well, it's very versatile because you can use it for, like, if your facility has it, you can use it for PRP and you can use it for BMAC. So it's very versatile in that aspect. It's automated. There's just like kind of like a one procedure to it. It's not like multiple spins. It's closed, so sterility is also, it's like a beneficial in a sterility standpoint. And then it's simple. And then you can use it for aspirate and PRP, like I said. And I'm sure we'll talk about the Vortex needle, which I think is a great
Absolutely.
innovation.
Yes.
But so those are some of the reasons.
Perfect.
That's coming up next.
Yeah.
I know. Yeah, I don't want to jump the gun.
No, it's okay.
perfect.
That's good.
Yeah.
So, it sounds like that angel centrifuge system, has a lot of great pros to it. Another thing is to control that hematocrit level. We know that in the biologics literature that concentration or dosage matters, right? It's like taking a medication for high blood pressure. You have to get the dosage correct. So I think that's really beneficial. Now, in terms of the other equipment for the harvest, are you utilizing that Vortex needle that you just alluded to, or are you utilizing this in conjunction with the angel system or alone?
Yeah, so there's a standard needle that we use for a long time, and it's a very simple system, right? The standard needle, again, you're taking bone marrow aspirating bone marrow essentially, and you're spinning it, and you're getting a concentration of growth factors, and you're getting a concentration of cells potentially as well. But what the Vortex needle adds is side fenestrations, right? So the point of that is, as you aspirate, you can kind of spin it back. And so you're getting new kind of growth factors and new bone marrow from each level. And the thought is, and like some preclinical studies obviously show, is that at each level, it's more rich in growth factors and in cells. So what you can do is actually not use the centrifuge at all. You can just use the Vortex needle. And I have different procedures like when I'll do what. But my ideal scenario is actually using the Vortex needle, getting like fresh cells and bone marrow from each layer, and then spinning it. And so you're concentrating already concentrated product. So it's really best of both worlds.
Yeah, I love that. And I think, people do want to know, like, are there times where you're not using that Vortex needle, where you don't think it's necessary? And, how do you decide whether to centrifuge or not?
So now I pretty much always use the Vortex needle, but whether I decide to centrifuge or not, it's actually like practically timing wise. So like, let's say I'm going in a case on osteochondral allograft. So I like pretty much know I'm going to do it. So I'm going to take the bone marrow aspirate right away. I'm going to spin it, and it's spinning, and whatever it takes 15, 20 minutes, it can spin while we're like doing our approach or while we're harvesting our graft. And then once it's done spinning and we've irrigated out the graft, right, to remove bone marrow elements, then we can let it sit there in the bone marrow aspirate.
Sure.
And that's great. And then you finish your approach. Now, the scenario when I haven't necessarily spun it is when I'm like fixing like an osteochondral defect, like repairing it, maybe probably a younger patient, maybe an adolescent patient, and I'm not sure if it's going to fit. So I might not take the bone marrow right away.
Okay.
Because like I'm either getting rid of this and we're just doing a removal of loose body, or I'm fixing it. So I don't necessarily want it, although you probably could, I don't necessarily want to take it if I'm just doing removal of loose body. Yeah. So in that, like I had a case where we were able to fix it. So, okay, we're able to fix it. Let's take the bone marrow aspirate, and then we don't really want to wait around 20 minutes patient under anesthesia. So we can just kind of like have it ready right away.
Great.
So we can sit in that as we do our final preparation of the defect.
Sounds like the Vortex needle is really helpful in that case because it gets from those different levels due to that fenestration, and that improves biologic quality. So in terms of needle design, we're going to talk a little bit more about that. So are you choosing a closed tip or an open tip needle?
Right. So if you want, that's good. That's a great question. So if you want to, there's pros and cons of both. So if you don't want to wait for your spin and you want the highest concentration of bone marrow aspirate, like no dilution, you would use a closed tip needle, meaning the end of it is closed. Now, that probably will take a little bit longer to actually aspirate it up as you go up. So it might take a little bit longer, but when you don't spin it, it's theoretically like highly concentrated and good quality product. But if I'm going to spin it anyway, then I'll probably use an open tip just because it comes up quicker. Like it's a bit of an easier process.
Makes sense.
Yeah, that makes sense. So for someone who's starting out with this in their practice, there's a learning curve for everything. So we always want to learn from those before us that have done it. So what are the pearls and pitfalls you would say to someone who is starting to integrate this into their practice? What can they learn from you?
Yeah, so if I know I'm going to do it, then we have the patient supine. I have the tech set up like a small side table that's like, it is sterile, but I don't like gown up or anything. I just put sterile gloves. Then with kind of like blue towel, drape out the iliac crest, prep it, drape out the iliac crest. And then I just kind of like really feel the inner and outer table. I'll make like a slight nick with an 11 blade, and then I'll kind of go in with the needle. So I'll usually just mallet it in. You can go under power, but I just feel quite controlled, like under just mallet it. And then with the Vortex, you can twist it in nicely as well and just like corkscrew it in. Now, okay, so what are some of the pitfalls? Sometimes you don't get blood back right away. So you can do a couple things. You can try to readjust. You can back it up. Maybe you're in too deep. Or maybe you just need a new spot, but like without making another nick or incision, you can just kind of find a new spot, go ahead on in, and then usually by second time I've gotten it.
Great. So now that's technique. Now in terms of integrating it into OR flow, right? So a lot of times we hear from surgeons, I don't want to add this time to my case. I don't want to do this. How do you optimize kind of integrating this in? You said you have a team. You talked about how you prep and drape it. How do you integrate this into some of your surgical cases where you want to bring this in?
Yeah, I'll brief everybody and just let them know. I'll book it with it. I'll book it with knowing that we're going to do bone marrow aspirate. I'll brief everybody, and then it's probably like 5-10 minutes in the beginning. So it's not like a huge deal. And I think there's a lot of benefit for that 5-10 minutes.
Yeah, absolutely. So, we know all of these things are going to evolve. As far as where the future is going, specifically with BMAC, where do you see things going, and what are you excited about?
Well, there's a couple things. So it's really kind of like, it's been around a long time. And I remember doing bone marrow aspirate in residency like 10 years ago, mostly for nonunions. So I think we didn't really speak about this, but there's a great aspect of like a not necessarily sports medicine field, but like more of a trauma or non-union. And a lot of us do clavicles and trauma work anyway. So we know about it for that. We know that there's definitely benefits in symptomatic arthritis. And there certainly appears to be a benefit in kind of like osteotomies or cartilage, osteochondral allografts. And it kind of makes sense, right? Because we're doing bony work. So let's take bone marrow aspirate. So that makes sense. Now, where it's going to go in the future? Well, a couple of things. We don't really know all the applications for soft tissue yet. We don't know if rotator cuff. So there's a lot of work on biologics and rotator cuff right now, patch augmentation, for example, or dermal allograft augmentation. So maybe combining it with that is something that we'll look at. And then we also don't really know like how to make an ideal concentrate. Like what, for example, in PRP, right? How do we like optimize someone's platelets? So it's kind of the same. How do we optimize someone's bone marrow? Is there something we can look at? Can we avoid anti-inflammatories? We do that in PRP. We don't really do that in BMAC because it's not platelet driven. So there's a couple things that we need to know as far as like, we know it's powerful. How are we going to use it in the future? And how are we going to optimize it? Oh, and the final thing is, I think in the next like decade, we are probably going to learn a lot more about stem cells, right? And I'm cautious to say this is stem cells because it is probably a low amount of mesenchymal stem cells. But if we're able to manipulate stem cells in the future, then there's a chance we can like do something with bone marrow aspirate, manipulate the stem cells, and that would probably lead to some pretty potentially impactful outcomes.
Now you mentioned fracture surgeries, non-unions. What about revision cases? Do you feel like you're adding it in those? Are there any specific cases that come to mind recently that you've done that you felt like really helped you harness the patient's biology in terms of optimizing their healing?
Yeah, so we're always trying to make the outcomes better. So and there seems to be a very low risk of using bone marrow aspirate. So anything we can do to add to it, I think is great. We don't really know, but common sense says, like, let's say you're doing a revision ACL, maybe we could add it to the graft, or maybe we can soak the bone plugs in it, and maybe we can get better integration that way. Maybe we can do quad ACLs, and we want that bone to soft tissue healing. Maybe if we soak it in there, maybe we'll get a better outcome. Maybe we can wrap our grafts in some sort of biologic and add bone marrow aspirate to it. So as far as revision cases, that would still be more bony chondral work for me. But I think that there is an opportunity for advancing research on this, and it's quite exciting, actually.
Absolutely.
Yeah, I agree. I think those revision cases are a big one. We're always trying to think of what else can we add to sort of help this process alone, whether it's like revision cartilage or revision tendon repairs. So, anywhere where that biology is compromised.
And if you think about if somebody's having a lot of effusions, this is probably very effective as well at like kind of bringing down their effusions. A lot of athletes will get effusions; they're just used to it. Their knee is like used to being like inflamed after surgery. So if somebody's having a lot of effusions, I will consider adding a biologic, and I think that helps keep it down.
Yeah. And we've asked this on our biologic episodes before to guests, and it's sort of all over the spectrum. Do you give, if it's a pure biologic procedure that you're doing, do you give them any restrictions or any formal therapy?
Such a good question. It's all over the map, right? Some of like my non-operative colleagues for PRP injections will do like crutches for 6 weeks.
Mm-hmm.
So in my athletes, especially like the hockey players I take care of, it's hard to go 6 weeks non-weight bearing, or like in your midst, you're like kind of like maybe you're at a break, or we're in the Olympic break right now, which is a good example. So we've been doing biologics on our players, but what we'll do, the answer is we'll do like 1 to 2 weeks of modified activity, not necessarily crutches certainly, but we'll just kind of like a modified shutdown with some active recovery, and then we'll build it up from there. So 2 weeks of like modified activity and then return is what I do.
Yeah, fantastic.
Yeah, that makes sense.
Yeah,
absolutely. Well, thank you so much for joining us today for this. This is really insightful. We've done, as I said, we've done a lot on orthobiologics, but not specifically for BMACs. We really appreciate your insight here.
Yeah, it's awesome.
My pleasure. Thank you.
Yeah. And thank you for joining us for this episode of the Sports Talks podcast, live at the Arthrex Team Physician Controversy Conference. We hope you enjoyed our discussion today as much as we did. Be sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine.